We'd like to begin by sharing some statistics that shine a light on the impact Parkinson's has in our country, as well as regionally. Every 6 minutes, someone in the US is diagnosed with Parkinson's. This translates to about 90,000 individuals per year, a 50% increase over the previous estimate. In Oregon, it's estimated that annually about 1,100 people are newly diagnosed. And approximately 15,000 households are touched by PRO services each year. PRO is local and direct in our efforts to provide customized programs and individualized services. Our topic today is optimizing communication with your healthcare team. We greatly appreciate our two guest presenters from OHSU and Providence Health for taking time out of their very busy day in the clinic to join us. I'd like to now introduce them. Jeni Bednarek, RN BSN, is a nurse team coordinator and associate director of education for OHSU Neurology's Parkinson Center and Movement Disorder program. Jeni has been working with the OHSU Parkinson Center since 2021. And Theresa Harczo, RN BSN, has been the clinic program coordinator at Providence Brain and Spine Institute for the past 5.5 years. Theresa supports care for all Parkinson's patients seen by Providence's movement disorder specialists at both the St. Vincent's and Providence Portland Clinic. And I'm Mike Mulligan. I'm the Community Health Education Coordinator with PRO. And Melissa Greer, our Program Director, is also with us to help manage the online event. I wanted to start with giving kind of a high-level look at today's healthcare landscape. According to a 2022 article in Health Leaders, the average wait time for a physician appointment nationally was 26 days, a 24% increase since 2004. And Portland had the highest in the nation at nearly 46 days. One factor in this backlog is simply that people delayed seeing healthcare providers during the pandemic. So we're still playing catch up, but there are other factors at play. A large portion of the current physician pool is nearing traditional retirement age. The Association of American Medical Colleges estimates that by 2034, the US will be facing a shortage of just under 38,000 to 124,000 physicians. And these estimate shortages will be dependent on the decisions of these older physicians to continue working. However, the number of new physicians that can be trained is relatively fixed due to several factors, including the number of medical schools, their capacity, and the funding for internships and residencies. Surveys also point to potential increases in provider burnout, which may further impact patient access to care. And staffing challenges are not limited just to physicians. Even prior to the pandemic, a gap existed between the supply of registered nurses and the need. This situation is likely to worsen. The nurses ages 25 to 44 make up the largest share of the workforce. Yet in 2020, this group saw the highest percent decline. And meanwhile, the number of nurses ages 65 and above hit the highest level to date. Overall, the US population is aging. By 2035, there will be more people over the age of 65 than kids under 17. This translates into an increased number of people who are requiring more frequent and more complex care. And our overall population is growing too, which means demand for care will only increase. When we look more closely at the need for neurologists, ideally, an individual with Parkinson's will see a movement disorder specialist. Unfortunately, there are not enough of these physicians, and they are not available in many parts of the country. In fact, according to a MedPage Today article, over 40% of Medicare beneficiaries with Parkinson's do not see a neurologist of any kind within 4 years of their diagnosis. The challenge really is that it's difficult to first get an adequate number of physicians trained as movement disorder specialists, and second, then locate them in a geographically effective manner to meet patient demand. When we look at rural communities, it is often challenging to find a primary care physician who will work to help manage a person's Parkinson's, let alone have a neurologist available. This can create a significant burden of traveling for care with associated costs of travel and lodging that can often be prohibitive. Across many clinic settings, the use of telehealth increased significantly during the pandemic. As we've noted, geographic distance, level of disease acuity, and distribution of physicians are all barriers for individuals with Parkinson's. Telemedicine can help overcome these. Studies have shown that individuals with Parkinson's are very satisfied with the telehealth experience. In fact, according to a Parkinson's Foundation COVID-19 survey, 46% of individuals who started using telehealth during the pandemic hope to continue having that option going forward. However, technology challenges remain. Access is the major one. As Holly Chamoff, PRO's executive director, noted in a 2021 panel discussion, Oregon is 36th in the country when it comes to broadband access. This, in fact, impacts a large portion of our service area. Our goal here today, given the current challenges that everyone involved in healthcare faces, from providers to patients, is to give you insights and offer practical advice on how to best communicate and work with your providers. They and you have a common goal: achieving the best treatment and management of your Parkinson's disease possible. And I'm now going to hand it over to Jeni.
Thanks, Mike. I'm going to talk a little bit about understanding how the healthcare system works. So you can go to the next slide, Mike. So the big takeaway of this part is that it's your job to learn how each clinic or system works. It's not a fair ask, but that's unfortunately where we're at. So when you see a new provider, or if you are established with someone and you haven't asked these questions, I recommend that you ask them, how should you communicate with that clinic or that provider's office? Do they prefer phone calls? Do they like those patient portal messages? Is there another way that they like you to communicate? Some clinics will have one phone number for scheduling and one phone number for medical questions. They're all set up differently, and you have to know what each one prefers. So the other thing would be, who do you ask for? You know, some clinics have just one nurse who does everything. Other clinics will have, you know, 3 or 4, 5, 6 different people who all have very specific jobs. You can go to the next slide, Mike. So who sees your health portal messages? Typically, and this, I can't speak for every clinic, but typically those messages go to an MA. They might go to, we call them patient access specialists, or somebody who maybe doesn't have even any kind of medical certification or license. Sometimes nurses will see those messages, but they rarely go directly to your provider. So just know that when you're sending those patient portal messages, they're going to be filtered through support staff before they reach your provider. So if you're having delays in getting a response, know that that's because often there's a back and forth happening between that support staff member and the provider, and they may be trying to work your problem out. So that goes into the next question: how long should it take to get a response? And it depends on the clinic. They all, I think, have kind of different benchmarks. I know at OHSU, we have a general system-wide message that's on our patient portal messages saying you should get a reply in 2 business days. We usually say that doesn't mean that your issue will be resolved. It means that someone will have seen your message. So again, that goes back to those questions to ask when you're in clinic. You know, how do I communicate? What's the best way for different issues? So, you know, if you have like an urgent medication request for OHSU, it's probably not a good idea to send a patient portal message, because it's going to take us a couple of days to see your message. And we would tell you to give us a call, but that may be different for different clinics. Maybe they want that through their patient portal. So that goes right into the next one. How do you request a medication refill? I think we've all been on hold before with a provider's office and heard the talk track of please request refills through your pharmacy. And that would be my recommendation. Your pharmacy sends a request with all of the information that's needed. They send the request with the pharmacy the medication needs to go to, with the medication name, the dose, how you're taking it on their end at least. And then that can be reviewed on the other end. We do know that in Parkinson's and movement disorders, there are a lot of medication refill headaches that can happen. So your insurance might deny the medication and need a prior authorization, or maybe the dose changed. And so when you're requesting the prescription, it doesn't look correct on your end. So there are definitely reasons to contact your movement disorders provider's office, but the first step is usually to try to work with your pharmacy. It's the most efficient way to do medication refill requests. And I think that's it for me. Or do I have one more slide? I think I'm done. So I'm going to hand it off to Theresa.
Thank you, Jenny. Hi, I'm Theresa. So I've got some really important things that we're going to want to talk about. I'm going to go through a variety of slides. Thankfully, they're going to videotape today's event, so that way you can always go back and review it once again. I always welcome people to take snapshots with their smartphones if necessary of the slides as well. I have a tendency to do that. So diving in, we're going to talk about how to make the most out of your clinic appointment. So moving on, thank you. Okay. Doctor has a set template of time allotted per visit. You're looking at 30 to 60 minutes on a basis. It could vary according to organization. So at Providence, 30 to 60 minutes, which goes really fast. We highly recommend that you come prepared to your appointment with maybe your top 3 concerns, things that are your top 3 priorities that you want to make sure are addressed during that meeting. Now, the provider is most likely going to, bring up other questions too. So anything that's after the top 3, it might be addressed. Those are just bonuses, right? So with that, making sure you bring the most current up-to-date list of your medications. Not always do we have the most current up-to-date list in our electronic medical records, because you might have providers that are outside of the Epic system, which is a large electronic medical record system that we use, Legacy uses, OHSU uses. So it's not always up to date. And so you want to make sure you're telling us which ones are new and which ones you've discontinued of recently, like maybe the last couple months. Sometimes when patients come in with some concerns of a symptom change or something going on, it could be because of a discontinued med or a newly started med by an external provider. So that's why that is so important. In other cases, if you're new to the provider, a really brief bulleted summary of your medical history. A lot of times we will get the records transferred over, so that way the provider has a quick review of that. But having it there, especially if some of that's newer material or information that you want to share, you had a hip surgery in the last 6 months and you have Parkinson's and you're having troubles with your gait, well, then we have a little bit more to filter through in the appointment, and understanding that you had a hip surgery or knee surgery or whatever that might complicate things. And so we can try and help figure out which we're treating here, which should be the Parkinson's. So it's that part. Number 1, for anybody and everybody, we always like to think of ourselves as an honest and trustworthy person, and we are, and we go in with good intent to meet with our providers. However, we might have some things that have been happening that either one, we're afraid to tell the doctor, or we're just not thinking about it. And certain types of things I'm mentioning here is if you're having a lot of dizzy spells. So some people actually just kind of collapse out of nowhere all of a sudden. We get phone calls for things like that. What do? She's down on the ground. It's like, oh, you call 911. But it's not always in that situation. But if you're having, a lot of falls, you want to always share that. You don't want a cane, you don't want to use a walker, so you might not want to share it, but you will most likely be asked. Please be truthful. The one that I think that scares people the most that they hold back is hallucinations, confusion, delusions, seeing a coat rack and thinking it's a person. These things can be brought on by the medications. So we always want to know about these so we can help you. It's not to hurt you. We're not trying to make life worse. We're trying to keep you safe. So be really open and honest about what you're experiencing. Okay, Mike, next screen, please. Okay, so you've got this limited time meeting, which 60 minutes can seem like a long time and 30 can be well used. However, you might have some questions or some other things that come up later. And I'd really like to encourage you to be open to having somebody other than the provider follow up with you regarding that. And that could be somebody like Jeni or myself, a nurse, following up and talking with you about some additional things you'd like to have addressed. And again, going through, if you're newly diagnosed and you're talking with the provider, either, if you don't think about it while you're there, asking for additional education material or any exercises that are really good for people with Parkinson's. Nurses can definitely help with that. The medical staff in general, a lot of times have resource material they can provide you. So some things like that can be helped by the ancillary staff other than the provider. Then there's that time too, where maybe you're a brand new patient and you're going in to see your neurologist or movement disorder specialist for the first time. Think about maybe having somebody accompany you. Doesn't mean you need them there for any help, maybe to hold on to their arm or something like that, but I'm talking about having a second set of ears, listening in, being able to be a good, strong support person for you with a new diagnosis, if that's what happens at the first visit. This is really helpful. Some people I have talked to, actually quite a few, people that are newly diagnosed, it takes a lot of digestion and you're processing and you're starting to get concerned or you have fears and you start Googling the web and all these different vetted, unvetted, I'll put it that way, websites, vetted websites we can talk about another time. But, the big guns, you want to use, Providence, OHSU, Pro. You want to use Michael J. Fox, Parkinson's Foundation, Brian Grant Foundation, places like that, and many others. But just having another person maybe accompany you or every time so that they can continue to be your support person. Please try not to ever leave a visit feeling like that you don't understand what changes or things are taking place, because we want to make sure that you have been heard, that we've listened to you, that we have provided you a good treatment plan if necessary. If you choose to hold off on medications or exercise or referral for speech or physical therapy, all of that needs to make sure that you are stepping away knowing that you have a care plan in place. Okay, slide, Mike. Tips to share with you. As Jeni kind of mentioned earlier, we do in today's society find ourselves having to be a little bit more of our own advocate in regards to our care. Things have changed a lot over the last 10, 20, 30, 40 years. Yes, I've been around that long. Anyhow, be an active participant in your care. Educate yourself. Prep for your appointments, like I talked about. Have your top 3 priority items, kind of at hand, knowing that those things are things that you want to make sure you step away knowing the response, answers, and recommendations to. Prepping for the appointment is like doing those, putting down your medication list or having it already typed up, and bringing that in, and be ready to speak up for yourself. I like a patient that is comfortable doing that, but not everybody is. And again, I'm always happy to kind of come in and help support you as well on the backside. Again, it does take a nursing time for all of that, and not all organizations do have the nurses available to be able to do that. So try and feel comfortable in asking questions or question the provider why do you recommend that? Or, you know, what are the side effects if I were to take that? And make sure that you feel comfortable with it. Because of the brief time that you have with that provider, keeping on task, staying focused with those more higher quality and important topics that are to be addressed are addressed. Now, I'm going to go ahead and ask Mike to forward the slide one. And on this slide is a copy of a sample. And so this is what I call as a symptom diary. And it's something that you're welcome to use. Mike will forward out a copy of it to you after everything is completed with today's event. And what I use this for is I have patients create one a day. And if you can just take a look at it, we're not going to go over it in depth. It has all the hours of the day along with symptoms and medications and a little space to add additional notes. And if you keep one of these daily and you take it to your visit or you use it for follow-up calls or send it through MyChart or the patient portal, it's really helpful to identify any wearing off times or when you might have dyskinesia, when the dosing times correlate or don't correlate with them. And so it can be very, very helpful in helping manage your treatment plan, medications, and dosing. So this is just a sample. You don't have to use it, but it's something to kind of let you know. It's really helpful for us to be able to identify what we can do to help you feel better in your everyday life. All right, Mike, on the next slide. Thank you. So Jeni did allude to, you know, and I think Mike did a little bit about using the health portals, and that's either called MyChart or, you know, patient portal. Every organization might have a different name for it. If you don't have access to it, and not everybody does, highly recommend maybe asking a staff member, the front desk person, the MA, I'm not quite sure at your clinic, who has access to send you the link to set one up. Once you get it set up, it's your link to basically like emailing back and forth. It's really best to keep these messages short. As Jeni said, at her organization, it can take 2 days before it's touched or seen. And the same thing at Providence, it goes through a filter of hands. People are going to look at it and say, oh, this needs to be routed this way, or it needs to go that way, or it needs to go to Theresa. And so keep in mind, it does take time. So keep them kind of brief and to the point about what the topic is that you're reaching out to us for. If you find that you start writing a lot, then that's probably going to need a two-way conversation. So be prepared to either have a lot of basically messages going back and forth for clarifying or a phone call coming your way. So that's that part. But what's nice for the portal too is we have some patients that need specific kinds of disability forms or send over their symptom diary, and they'll, I don't know how, I don't use my portal, I'm bad. They scan them in somehow and they get them into the MyChart or into the computer system at the office, and then we're able to look at them. And they do become a permanent part of your record. So keep that in mind too. So be mindful about what you write, okay? So those are good ways and good reasons to use the portal. Keep it quick and short, so that way we can look at it, identify the needs, and reach out to you with a response. All right, we've got another slide coming up here. Okay, so on this particular one, it's about virtual appointments. And I have my own little joke is that it's almost not funny, but thankful for COVID and not thankful for COVID. During COVID, Medicare opened up all the lines in regards to virtual visits, and it's wonderful. It has made it so much nicer for patients with fear for coming in of getting sick, right? Well, we kind of had to do that. The concern, though, of how do you get your computer to work and how you get it going. We all had to fast-paced learn that one. Not worrying about the mobility problems and challenges and transportation, and being able to see your provider still on a virtual basis on your computer or electronic device. Lowered the number of no-show visits to the clinics when patients typically come in, has made that so much easier. It a contact with patients, still personal. We've had to learn that because it felt impersonal originally. I think a lot of people are used to being face to face and having the provider, do specific movements and checking out the joints for stiffness, right, and rigidity. But the virtual means is extremely easy and nice to use. Except for those I have found, and not always, is that if you live across a river and your provider's on the other side, there's something about the body of water. It just stops you dead in the tracks. You just hate going across the Willamette or the I-5, right? And going across Columbia. But it has definitely made things so much easier for us. So keep your fingers crossed. We get to keep doing virtual visits. We still will need to see you in person. And let's talk about that on the next slide, Mike. Thank you. Well, why do we need to see you in person? Well, it is very nice to be able to have virtual visits. I've seen some people have virtual visits for over 1.5 years straight, and then we're finally saying, guess what? We need to see you in person. We still do need to, at some point in time, be able to have that hands-on, eye-to-eye contact. The overall evaluation via virtual is worked out pretty good, but not everybody is capable of setting their in-home camera up well enough to be able to really see the gait, see how the feet are picking up or shuffling on the floor, watching the gaze of eyes. There are other Parkinsonism type neurological disorders that they need to see how the eyes are moving to help establish if that's a possibility of the diagnosis. So there's just various areas of being able to move the wrist, move the head around, really feel the strength in the legs when you're doing your heel taps, things like that. So try not to be too opposed if and when the time comes for you to come in and be seen personally. So that is one of the good reasons for you to come in. Now I'd like to loop back around to the last slide that I have to share with you, Mike. It has to do about how important it is when you do have a person in your life, whether it be a caregiver, paid or friend, a spouse, a loved one, somebody who starts attending your visits with you on a more regular basis. Now, as we know that with Parkinson's, for some people, you start having some difficulty with speech, not all, but your voice gets very quiet, hypomania. You're not able to project your voice and speak as well. For some, there might be some cognitive changes, maybe some difficulty with word search and finding and finishing your sentences. I've probably done it a few times here already. However, there's those that, just might not be a good historian any longer, maybe meaning not being able to recall some events or recall certain things that have happened that the provider's asking questions for answers. But you bring somebody with you, but it's nice for you to have a good conversation with that person you bring along as to their role. We want to make sure that you're respected and that your dignity is also upheld, and making sure that if you want that person to be your primary speaker for you, that needs to be an agreement. Because when you come in, like myself, when I see a patient, I'm going to look at the patient. Thank you for bringing the patient. However, how are you today? Are you going to be able to respond back to me? Are you going to shake your head? Are you going to, be able to verbalize that? I do need to see that. I need to hear it, just like doctors and movement disorder specialists need to see that and hear it. It helps us identify if we need to place referrals or any other types of things that we can help with. If the conversation seems to be one-sided, where we're uncertain, sounds like you can speak for yourself, but the person that came with you is doing all the speaking. Sometimes we will regear that conversation back to the patient, clarify that it's okay for them to speak on your behalf, or if you have any additional input to do. We do want to make sure that you are part of the appointment and that you are well heard and cared for. So that's what I had to share with you today. I'm just kind of wondering about if any of you have had any of these types of conversations or concerns. And if you do, make sure you put the questions in the chat feature or hold them off until the end of today's event so we can answer those questions for you. I want to thank you for your time. Go back to Jenny.
Thanks, Theresa. I think the last thing we're going to talk about is avoiding a care crisis. So you can go to the next slide, Mike. So the biggest thing is consistency of your care is important. I know, Theresa, or that this was touched on in the very beginning, that everything got a little jumbled with the pandemic and access to providers was difficult, and we did the switching to video visits. And so I feel like we're definitely still playing catch up with that. And we have patients that we kind of catch in our clinic all the time that haven't been seen in 2 years. So if that's you or somebody that you know, make sure that they get seen for follow-up. One of the things that we recommend is that you have a conversation with your movement disorders provider about what to do in emergency situations. We know that, you know, sending a person with Parkinson's into the ER is sometimes means that things might happen that wouldn't happen to a patient that didn't have Parkinson's. There are medications that shouldn't be given that can make Parkinson's worse. And then also just access to your medications on time when you're in the hospital can be tricky. So strategize with your provider about what to do in certain situations, what their recommendation is, so that you can have that conversation before you need to be having it, calling us while you're in the ER, which does happen pretty frequently. If you need to cancel your appointment with your movement disorders provider, make sure you do that with as much notice as possible. I know in our clinic, most of our providers are booked out at least 6 months. So if you are canceling and trying to reschedule and, you know, I'm only going to be around in town between these two days, it's going to be very difficult to accommodate that. So just understand that when providers are able to accommodate very specific requests like that, they are often putting you into spots where they actually didn't even have appointments. And so it's very difficult to get people rescheduled in a timely manner right now. If you have a DBS device, a deep brain stimulator, one of the things that is your responsibility is to check the battery regularly, once per month. I know for us, we have about a 3-month wait for battery replacement. We ask people to check monthly and we'll tell you at what level you need to let us know, because then we can get you in for a replacement before the battery dies. But if you're not checking it and you call us and say, oh, my DBS battery died today, it may be a couple of months before you can get a replacement. So I know there are probably other clinics that can get you in faster, but I'm not sure it's that much faster. Next slide. So if you have Parkinson's disease, we generally say there aren't any emergencies in Parkinson's. I know it feels like there can be an emergency on your end, but from a healthcare perspective, we don't see sudden changes in Parkinson's symptoms, and we don't see significant changes over a short period of time. So if you're having a problem with new Parkinson's symptoms or a sudden and significant increase in your Parkinson's symptoms, the first thing we want to look at is something else going on. What's influencing your Parkinson's that isn't actually your Parkinson's getting worse? Do you have a urinary tract infection? With COVID, we're seeing Parkinson's symptoms flare up before COVID tests are positive. So even though you might not feel like you're sick or feel like you have some kind of underlying infection, often your symptoms can be that canary in the coal mine. Something's off with your body, and it's time to have a conversation with your primary care provider about getting that checked out. If you aren't sure what to say to your primary care provider, I would just let them know, hey, Parkinson's symptoms can flare if I have an underlying infection or virus going on. I haven't made medication changes. I don't have any new stress in my life. I haven't had any medical procedures recently. And I just want to make sure there's nothing else going on here. And they should know how to check you for an underlying infection or you know, we can do COVID tests at home, but they can do a COVID test, order one for you as well if you're worried about that. Next slide. So I think the first point is just that other health issues can come up and they can definitely impact your Parkinson's symptoms. If your primary care provider runs tests and they don't find anything, they can communicate with us. They might right now tell you to talk to us. That is often what happens. And we're happy to hear from you. You know, when you send a message to your Parkinson's team, make sure to include that you've already worked with your primary care provider. That way we know, hey, we've ruled out underlying infection. Let's strategize. Let's see what else might be going on. So a question that we get a lot, and I'm sure Theresa gets this all the time too, is, okay, well, who do I talk to about what? You know, GI issues, sleep problems, mood disorders, pretty much anything. Pain is another big one. So who manages that? And the answer is it depends, which is not a fun answer. It kind of depends on your individual journey and your healthcare team. And so these are things to talk about with both your primary care provider and your movement disorder specialist. Your PCP is the hub of your care. They should know everything that's going on. And so, you know, often they will be managing mood disorders. They may be helping you with sleep. They may be helping you with GI issues. And that is appropriate for them. But sometimes your Parkinson's or movement disorder specialist manages those things. So it's definitely a team approach, and it really does depend on your individual situation. So if you're not sure, I would ask both providers what they're comfortable managing and what they would like to manage. Your movement disorders provider will make referrals for physical therapy, occupational therapy, and speech therapy in relation to your movement disorder. So if you had an accident 30 years ago and have chronic back pain from it, your movement disorders provider is not going to put in a physical therapy referral for chronic back pain. That's going to be your primary care provider. But if you're having freezing, if you're having balance issues, we're going to put in a referral for physical therapy with somebody who is a neuro-trained physical therapist, and they can help you work on those strategies. And if there are questions about sort of those nuanced who does what, we're happy to answer those in the question and answer session. My last thing is drink lots of water. I am guilty of this. I say it because I think if I say it in front of a bunch of people, maybe I'll do it better job of it. But if you're feeling tired, if you're feeling dizzy, lightheaded, you know, sit down, drink a couple of full glasses of water and see how you feel. Often, you know, lots of symptoms, whether they're Parkinson's related or not, can be improved by being better hydrated. So my strategy is when you take your meds, take them with a full glass of water. You know, if you're taking medications 3 times a day, you automatically get 3 full glasses of water. If you take them 5 times a day, then you're ahead of the game. You're getting 5 full glasses of water. So I'll leave you with that, even though it doesn't have a whole lot to do with this talk. I just have to say it every time. So thanks, Mike. Oh, I have one more. Sorry. Falls are a common reason that people go to the ER when they have Parkinson's disease. And this is one where I would recommend you not call your movement disorders provider's office and wait for a reply from them. If you fall and you hit your head, you probably need to be evaluated. You can go to urgent care. You could go to your primary care office, but you know, within that day, it's a good idea for someone to just be able to lay eyes on you and make sure you don't need imaging. If you're having symptoms like confusion or vomiting, feeling really, really sleepy after you've had a fall where you've hit your head, then you either need to call 911 or right away. We would be very concerned that you have bleeding in your brain and that needs to be addressed immediately. If you hit your head and you're not having any symptoms and you really don't want to go into the ER, you want to monitor for any signs of change in cognition, change in gait and balance, any stroke-like symptoms, if you're getting really sleepy, any sort of change from your baseline, you need to go in and be seen. And that can be for up to, honestly, 2 weeks after hitting your head. You can have a very slow, small bleed that can happen. So just make sure you're in contact with your primary care provider and that they know what happened and that they can help you kind of monitor. So significant changes. So, okay, I went through that. Reasons to go to the ER and not call your movement disorders office and wait for their response is, chest pain, difficulty breathing, any signs of a stroke, a serious wound, especially wounds that you can't get the bleeding to stop on, a burn, and this would be a burn, especially over a larger part of your body, and then that severe bleeding. If you have a fever that is not going away and is not responsive to medication, and that would be another reason to go. Or if you're having an allergic reaction, you don't need your neurologist's permission to go. Those are emergencies, and you should go whether or not we say it's okay. And next slide, I think I have one more.
Nope. Actually,
that's you.
It's my turn.
All right.
Thank you so much, Jenny. So what we want to do is just kind of give a quick overview of what we've talked about today. And I think the big takeaways is recognizing that our healthcare system does face increased challenges. So we want to be thinking about what we can be doing to help navigate that system and being proactive, finding out, as Jenny said, how your healthcare system works, how they want you to communicate, understanding that is really going to help you to optimize your care. Also, just knowing, as Theresa was saying, what information does your care team need, and really having yourself prepared as you're going for that appointment or having the telehealth visit so that you're able to maximize the benefit of that visit and making sure they have as much information as possible to provide the best level of care. And also, when possible, don't shy away from using technology. It can help streamline the care, and it's something that is going to be a great augment as care going forward, as Theresa was saying. And finally, just understanding, as Jenny was just touching on, that balance of communication of when to be talking with your primary care physician versus your neurologist or movement disorder specialist. As again, recognizing that it's a healthcare team. We're all working together towards the common goal of your health and optimizing your care. So having that good communication with everybody that's involved is going to be very, very important. What we're going to do now is open this up for panel discussion, just being able to ask Jenny and Theresa questions that you may have. There's a couple that have come in that I'm going to share first, but then just feel free to raise a hand on virtually here or with your real hand, and we'll go around and allow you to ask those questions and have our panelists give you feedback. Just